Hi, welcome to this short animated film about the In and Out project. The In and Out project ran from July to October 2022 and looked at experiences of admission to and discharge from UK mental health hospitals. This film will explain the aims of the project, the research process and the findings. The In and Out project was conducted by Surrey Coalition of Disabled People, also known as the Coalition. The Coalition is a not-for-profit organisation which promotes the rights of disabled people across Surrey and North East Hampshire. The In and Out project aimed to explore what support could help individuals, their families and carers to safely avoid an admission to hospital for their mental health. What support could enable people to get well more quickly and have a shorter stay in hospital, and how discharge arrangements could be improved. The ultimate purpose of this research was to improve mental health for people in Surrey. The specific purpose of this research was to give health, local authority and voluntary, community and faith sector partners a set of co-designed recommendations to help them decide where to focus future funding to reduce the need for admission to hospital for mental ill health or mental illness. Our research team was made up of Alex Hurd, the lead peer researcher, Kirsty Smith, the trainee peer researcher, and Dr. Dawn Benson, the research supervisor. We all have experience either of mental ill health or of supporting loved ones with mental ill health. Dr. Dawn Benson, for example, a sociologist with a specialism in disability studies and inclusion and safety investigation in health and social care sectors, is a parent of adult disabled children and has experience of caring for someone who has been admitted as an inpatient to a mental health hospital. We firstly looked at existing knowledge on this subject by doing something called a literature review. This included looking at academic studies, reports, newspaper articles and documentaries to identify areas of interest. We then created 2 surveys which were available in various formats. One survey was aimed at people with lived experience of admission to a mental health hospital and their carers, and the other survey was aimed at mental health professionals and volunteers. The surveys were shared by Surrey-based organisations so that we could gather information from lots of different people. We also collected the input of a steering group made up of people with lived experience of admission, carers and mental health professionals. We met regularly with the steering group to hear their input on ways to collect data. Once the survey closed, we conducted interviews with participants who had expressed an interest in having a further conversation about their survey responses. These interviews were held online and over the phone during September. We also held 2 pop-up events, one at a local mental health hospital and one at a supported living facility in Surrey. This provided an opportunity for engagement with more participants, and we were able to speak to them over coffee and donuts about their experiences of admission and discharge. To get a holistic view of the admissions and discharge process, we also interviewed people working in organisations such as the police, ambulance and young adults advocacy charities. Once the data collection was complete, we began the analysis process. We initially used the Safety Engineering Initiative for Patient Safety approach, also known as SEIPS. We identified statements from interviews and surveys which related to the person, tools and technology, tasks, the organisation, physical environment and external factors. We then completed further analysis using a thematic approach. This involved identifying recurring themes within the data, describing them, and picking out quotes which evidenced these themes. The themes which we identified around admission were relationships. Participants reported a lack of communication around their care, difficulty in getting the right help at the right time, needing a holistic approach to treatment, the importance of professionals maintaining boundaries, and individuals being too unwell to know how to access support. One person with lived experience of admission said, "You've got comorbidity and early mortality just because we can't take responsibility for ourselves if we're not well enough. It took me several years to realise I'd become seriously ill, and all the time I was getting bounced from service to service, and I'd seen that happen. But when it happens to oneself, that awareness is lost because we're in the jumble of complex trauma and the stress disorders, anxiety and depression that go along with it." Respect and partnership. Participants discussed the need of listening to patients and treating them like human beings, and things being done to them rather than with them. One professional said, "It's almost like they're just trying to provide a tick box quick solution, like, do this, you'll be fine." And the young people are like, no, my situation in my life is more complex than a quick fix, and you've not listened to me. Accessibility. Participants spoke about the difficulty in accessing support and medication due to eligibility criteria, waiting lists, lack of consistency in care, and staff approaches to care. One person with lived experience of admission said, "At the time, I was keeping track of it, and then it kind of just rapidly escalated, I guess. Like everything was just way too much, and then I was waiting for responses from community mental health recovery services and loads of different support services. Sort of trying to reach out to like everyone at once. But then obviously there was a big waiting list and stuff like that, so I didn't get much back. And then things just started getting a little bit worse and in a really bad place." The themes which were identified around discharge were unmet needs. Participants spoke about physical health needs being disregarded, experiencing boredom and isolation, basic needs not being met, and having their discharge delayed due to a lack of accommodation for them to go to. One carer said, "We've always felt that they, mental health hospitals, ignore the physical illnesses the patient might have or believes they've got. You just feel that the physical person is being ignored and they're only concentrated on the medication and that's it. And if you get any extra help, well, you're lucky." Containment, not recovery. Participants spoke about restraint being used, which elevated their distress, and sometimes there was a lack of therapy available, despite it being valuable. One individual who had access to therapy and activities during their stay said, "I had a good experience in 2018 at a mental health hospital I was in for a month, and I made rapid progress because there was a lot of activities and a lot of therapy sessions that went on during that month. That meant I got better quite quickly." Transparency and clear communication. Participants spoke about not knowing when they were being discharged or how they would get home, and not always being given a discharge plan. One professional said, "The first thing that springs to mind is setting a discharge date upon admission. I think that's really important. I've seen so many people just, weeks and weeks later they're still on the ward. Well, why are they still on the ward? What's the purpose of this admission? So timely discharge would be to set a date. Right, we are agreeing for you to be admitted for 2 weeks because we need to change your medication. So for 2 weeks, that is an adequate time to do that, or for whatever reason that person is admitted." Limited staff and resources. Participants mentioned staffing levels affecting access to certain activities during inpatient stays and affecting quality of care and safety. Collaboration between professionals, patients and carers was valued by participants, and they spoke about how this had led to positive outcomes in the past. One carer said, "She had at that time, in 2021, a fantastic social worker. The first time ever we thought we got somebody that really absolutely understood and had experience of people like my daughter before and really understood the issues. And she, this social worker, was able to make a connection with the hospital she was in. She attended meetings on our behalf if we couldn't get there. She was a link and she fed information to the hospital staff about, advised them really on what should be happening. And that was a huge contribution towards the success." Discharge from hospital and transition to community. Barriers to discharge were discussed, such as lack of funding and waiting for medication. Participants mentioned institutionalisation in terms of the difficulties of going back to normal life after being in hospital. They spoke about the need for carers to be included in discharge arrangements where appropriate, and considering patients as individuals who require tailored treatment plans. One person with lived experience of admission said, "Sometimes you haven't been out at all, or you've just been walked to the shop and back with a member of staff or something like that. And then suddenly you were expected to travel for about an hour and a half, 2 hours, to get home on public transport. It's unrealistic to expect it to go well, really. No wonder I keep getting readmitted." To learn more about our research, you can find a written report on the Coalition's website at www.surreycoalition.org.uk, or you can contact us by phone or SMS for a copy. Thank you for taking the time to watch this short film about the In and Out project. This research was only possible thanks to the generosity and bravery of people who had experienced admission, their families and carers in agreeing to share their experiences with us. We hope this research will be able to improve admission to and discharge from mental health hospitals in the UK. If you would like to stay up to date with future research by the Coalition, visit the research section on our website or contact us research@surreycoalition.org.uk.